Well, good night, good day, everyone. Welcome to our weekly session of Virtual Global Spine Conference. Um, we have lucky today of having Gaston Camino Willhuber. He's a very close friend of mine. He's from Argentina, but he's actually living in Spain after a couple of years living in the US. So we have today's topic is about thoracolumbar fractures, about the evidence behind these pretty common lesions. So without further introduction, Gaston, thanks for being here. I'm waiting for your comments on your lecture.
Thank you, Alfredo. Thank you very much for this great invitation. It's a truly honor to be here and to be able to talk a little bit about this type of fractures. You will see throughout this talk that we will discuss a group of heterogeneous fractures, and as a lot of things in medicine, we have a continuous patterns of injuries, and we are trying to classify it and categorize it. And that's where we have a lot of gray zones and a lot of debate of what to do, either surgery or conservative, and then what type of surgery. That's why we have a lot of doubts and uncertainty in what to do in this type of fractures. So through this talk, I will start discussing what is the evidence behind the general treatment, conservative or surgery. And then in a second part of the talk, we will be discussing the type of surgery that I will put main focus on the combined surgery, combined approach versus posterior only approach, and what is the biomechanics and things like that. So these are my disclosures. I'm part of the EOSpine, as many of you, and that's it. So as you know, the thoracolumbar burst fracture usually encompass 20% in epidemiology of the main spine fracture. So we got an important percentage of these fractures. And by definition, there is a compromise on the posterior wall, which is part of the middle column. And that means that we always gonna have in some way a little bit of canal compromise by a bony fragment that can be millimetric or a big fragment. And in some cases, some reports say that up to 30% of these fractures will have some neurological compromise. So as you can see, this is a very important topic from the prevalence and from the severity of the injuries and all the problems that can have. So in this, one second, yeah. So in this picture, you will see that the reason behind the frequency of these fractures, and one of them is like we are changing, we have a transitional zone from a rigid spine, which is the thoracic spine, which is rigid and kyphotic in shape. And the transition between the kyphotic spine and the lordotic spine, which is relative mobile, and this is the main reason why we have this the prevalence of these fractures in the junction, because we are changing the shape and the rigidity of the spine. And as you can see, you can have the two main type of fractures, which are the A3 patterns and the A4. By definition, by the EOSpine, there is a failure in the anterior and middle column of the spine. So 2 out of 3 columns in the spine are compromised. In A3, you have just one end plate, and in A4, you have the 2 end plates. So A4 represents a more severe pattern of fractures, and this is why, this is according to me, don't take this like a general statement, but this is a personal feeling that we have two different patterns of fractures that should not probably be compared together, because we are talking about two different type of pathology here. And one of the main problems or limitation of the studies is that they encompass these two type of fractures together. And that's why we cannot come out with a strong evidence of the studies behind it. So the radiological features that are important in these patterns, as I mentioned before, there is a loss of posterior vertebral body height. You can measure it, comparing the vertebral body height from the level above and below. There is a narrowing of the spinal canal, which in X-rays is kind of difficult to see sometimes. There is a widening in the interpedicular distance that you can see in the figure. You can compare it from the AP view. Usually is described being more than 20% or more than 7 millimeters in length compared to the level above and below. And in this type of fractures, two structures that you, or two components that you have also to consider is the assessment of kyphotics because of the deformity, the compromise of the vertebral body. And the interspinous widening is something that you have to do, you have to study, because it's not the same to have a pure burst fracture, which usually do not compromise the posterior elements, and you can have a burst fracture in the context of a type B fracture, which is one of the definitions of the unstable. So I'm not saying that the burst fractures always have a posterior element compromise. Usually they don't, but those are the things you have to check in the X-rays, because one of the paramount differences in the treatment, in the literature, in the evidence, is related to the integrity of the posterior components in a burst fractures. So I would like to stress the concept of unstable burst fractures, because many years ago, Dennis believed that all burst fractures were unstable, because he said that you had 2 columns out of 3. So by definition of Dennis, he believed that all fractures that have 2 columns compromised out of the 3 columns are unstable. Now we know that this is not entirely true, and there are other components that should be taken into account in order to define burst fracture unstables. So we have 2 main types of burst fractures, the stable ones and the unstable. And I would like to stress that again, because if you can diagnose unstable burst fractures, it's going to be a paramount difference in terms of treatment. What is the definition of unstable fracture? So you have to go back to the concept of White and Panjabi, that many of you probably remember, the possibility of tolerating the weight bearing without having deformity or neurological compromise are the main concept of the stability based on the White and Panjabi concepts. So those features or those characteristics that usually are present in unstable patterns of burst fractures, such as the injury of the 3 columns. So if in a burst fracture you have compromise in the PLC, in the posterior elements, you will have 3 columns compromised, 3 out of 3. This is a definition of unstable pattern. But then you can have spared. You can have the integrity of the posterior elements, but if you have a severe compromise in the anterior and middle column, you can also have an unstable burst fracture, such as the severe canal compromise, severe kyphosis, severe vertebral high loss, and neurological compromise. You can see that the 3 parameters in the middle are radiological parameters, and I have read these items in many papers. However, I don't think we should study these numbers and take these numbers so seriously or so exactly, because this is an accurate statement. Because, as you know, the thoracolumbar region encompasses the T10, T11 to L2, and we probably shouldn't consider the same amount of degrees comparing the T10, for example, with L1 or L2. The amount of degrees should not be used as the standard, because there are 2 different levels. So this is a particular opinion, a personal opinion. I wouldn't take the numbers so seriously in assessing the definition of unstable components. So these are the 3 questions that I usually ask myself anytime I see a suspect a burst fracture. The main questions with which I would like to start is the neurological compromise. As many of you can think, if we have a neurological compromise in the context of a fracture, this treatment will be probably more pushed over to the surgical treatment. The second question is if there is any PLC injury. As I mentioned before, there is a big difference in the 2 groups. If you have a burst fracture without PLC injury, it's totally different than the management of a burst fractures which have a PLC compromise. And the third question is that I ask myself is the comminution, how severe is the vertebral body compromised with the fracture? I didn't develop these questions. You will see in the classifications that we are going to discuss. But I think it's a good way to organize myself anytime I see a patient. Of course, probably the Q0 question would be if the patient is suitable for surgical treatment or not. If we have a 90-year-old patient with a frail and stuff like that who cannot tolerate the surgery, of course, definitely this is something important more than the radiological aspect of it. So this is an interesting paper that I want to share with you. This was published by Dr. Mohamed Ali from Egypt. He's a great spine surgeon, also belong to the EO spine. So he has done a lot of papers regarding the PLC injuries. And these are 4 parameters that he recommends you to look for anytime you can, in order to avoid MRI, you can do it with CT scan. And he explained why you should start with a CT scan. In some cases, you will need an MRI to rule out the PLC injury. So he found among these 4 imaging parameters, the horizontal laminar fracture, the spinous process fractures, the interspinous widening, the facet malalignment. Anytime you don't have any of these 4 parameters, the likelihood of PLC injury is really low. It's less than 10%. So you are 90% sure, because in medicine nothing is 100%, right? So we have 90% sure that the PLC is not compromised. So if we have a burst fracture, it's going to be probably stable. And on the other hand, if you have two or more CT finding among the four I already mentioned is the totally opposite situation, and you have 91% likelihood of a PLC injury. So you are 90% sure that this is a disrupt. And if you have a burst component, it's going to be unstable. But if you have just one CT finding, then you are in problem. You cannot rule in or rule out PLC injury, and that's why in this situation things indeterminate, and this is where you can go and do an MRI. And this is the paper I recommend you to read. Then we have the TLIX classification developed by Alexander Vaccaro. And as you can see, the components, the questions I've asked myself before are totally related to this classification. Personally, I don't like the idea of try to calculate every component and put in a table and see, okay, this number belongs to this treatment. This is basically not the way I proceed in my patients, but I like the components that are included in this classification, such as the morphology of the fractures. For sure, if you have a worse vertebral body components, probably the likelihood of a surgical treatment is going to be higher. If you have compromise of the PLC, as I mentioned before, more likelihood of getting surgery. And if you have neurological compromise, more likelihood of getting surgery as well. Then you will have a lot of papers saying, okay, what happens if the patient has 4, because it's a gray zone. And this is a gray zone because I mentioned because things like the one I mentioned early on this talk, in which you can see that the vertebral body fractures are a continuous pattern of injuries. And we are trying to categorize this in different scenarios, in different categories or groups. And that's where we make the mistake, or we have the gray zones, because you cannot have two patterns of fracture that's going to be equal. Every fracture is going to be different, and we are trying to group these patterns on different treatments. So you always will find patients that, according to a classification, probably will fall into a surgery, but they can do well on conservative. And in the opposite way also is the same. You can have patients with 3 in this score that do not do well with conservative and require surgery. And this is because medicine is not math. That's the way it is. So, and this is another classification developed by Eospine, and also Dr. Vaccaro was involved. It's kind of similar. It's basically kind of similar, but you have the case-specific modifiers and the treatment recommendations. But in this case, they try to, or they basically adapt the classification of the Eospine into this system, this scoring system, which is, I think, I like it, but I don't recommend personally to try to go and sum and, and write up all the numbers and see, okay, if this number is above some cutoff, it's going to be surgery or not, because I don't think this is the way we proceed in our clinics, right? We don't make a calculation. That's probably a job for AI or other programs, but not for human like us, in which we consider many parameters and the patients and all the situations that are not considered in these tables, right? And this is, again, A3 and A4, the burst fractures, especially the ones without neurological compromise, are probably the more difficult scenarios in which we we don't really know if surgery or conservative is the right treatment. And I will go to the literature to see what to do. So for sure, if we try to take out all the neurological compromise in situations in which we know that probably surgery is going to be the answer, such as PLC injury, nerve fractures, or neurological compromise, let's take out these parameters and just focus on A3 and A4 patterns in patients without neurological compromise. What we should do, conservative or surgery. Let's go to the literature to see what we have. So this is a prospective randomized study published in the JBJS. This is interesting paper because of the long follow-up, 16 to 22 years, which is incredible. They include patients from 18 years to 66 with an isolated burst fracture in the thoracolumbar region without neurological compromise and within 3 weeks of injury, so pretty acute injuries. And they randomized 47 patients, and 24 were to receive surgery, 23 conservative care. They have a decent follow-up rate considering the longer follow-up in these studies. And basically they found that non-operative care was had a better outcome at the end of the follow-up with lower low back pain scores and better ODI and Roland-Morris scores of functionality. And regarding the radiological parameters, they didn't find any significant difference besides some increase on kyphosis in the conservative group, which is expected. And in conclusions, the authors say that they believe that non-operative is the optimal management in neurological injured patients. So A3, A4 patterns without neurology, probably conservative was the best option. Then we have this interesting systematic review published in the core with a meta-analysis published in, I think, 2012. And they found between conservative and surgical groups, they found no difference in pain and disability, with slight more better kyphosis improvement in the surgical group and higher complication rate and cost in the surgery group. So, and if we go to the Cochrane database published the year after that, they mentioned that they found insufficient data to conclude superiority of one or the others, but they believe that they found that operative group was associated with higher complication rate, which is expected, and for sure the cost associated with surgery. This study, so we know probably that in A3, A4, without neurological components, we have a lot of evidence supporting the non-op surgery, the conservative treatment. So we're about to release this study that is going to be released in one of the focus issue in the Global Spine Journal, hopefully next month. In this study, we analyzed 183 thoracolumbar burst fractures without neurological compromise. And we compare a group of surgeons that were considered experts in the field with a lot of surgeons that actually treated the patients. So one group of the experts just observed the imaging studies, the CT scan, the X-rays, and MRI, and the other surgeons who actually treated the patients, of course, they checked the MRIs and the studies, and they treated the patients And interestingly, we only found a 63% of agreement between the surgery or conservative recommendation. So 4 out of 10 patients didn't match between the experts and the real treating surgeons. So you can see that imaging is not the only parameters that you have to check on these patients, because you have to see if the patient is willing to undergo the treatment that you propose. So there are many other factors that play a role in the treatment and in the final treatment of these patients. And that's why I feel like the randomization is kind of difficult in this type of studies, and that's why you have just few randomized studies. And honestly, if you think of yourself, we don't randomize patients when we treat them in the clinics. You receive a patient with severe fractures, and you don't ask the patient, we are doing a randomization, you will fall into the conservative group. No, the patient asks you, doctor, I'm in pain, what is the best recommendation that you have for me? So we have a lot of different more complex situation than just consider surgery or conservative in this patient. That's why A3 and A4 patterns are so difficult to understand what is the best treatment option, right? So let's say we decide to do a surgery. So we have the second question is, okay, what to do? A posterior only approach or a combined approach? What is the best treatment option once we decide the surgery? So this is a systematic review with meta-analysis of thoracolumbar vertebral fractures, in which the authors compare a posterior-only instrumentation versus a combined approach. What the authors found was that something that you can figure out. So we have a better kyphotic correction when you do a combined approach as compared with the only posterior approach. But on the other hand, you have more blood loss, as you can expect, more operative time, longer hospital stay, and a slightly higher rate of postoperative complications in the combined approach. Then similar studies have found the same situations. I put this paper because I like the final statement of the authors that say the surgeon selection of the type of approach, either posterior or combined, is biased, because usually in the real scenarios, the worst cases usually undergo a combined approach. So if you have a biased distribution of patients and the groups are not similar, the comparison will be not accurate, because if you are trying to compare posterior versus combined approach, but you have to understand that there is a selection bias behind these studies, because the worst cases usually don't receive just a posterior approach. You are more likely to indicate a combined approach. And every time we decide between combined and a posterior, we have to go back to this load shedding classification developed by McCormack and colleagues. Interestingly, this paper was published in 1994. Nowadays, we know, I'm pretty sure Alfredo will agree with me, that this paper would not be accepted nowadays in any journal unless you pay for it. You're not going to get acceptance because you have 28 patients. Even though the follow-up was long, with 28 patients, you cannot make a conclusion. But interestingly, the concepts behind the low shedding classifications remain. Even though there are not exactly as the author proposed, the concept, the idea of the comminution of the vertebral body remains in our minds when we have to face the treatment of these patients. So the more comminution you have, the more likelihood to undergo a combined approach, because if you do an only posterior, you will probably have a mechanical complication. This has been proven in biomechanical studies as well. You know, if you do a posterior approach, the studies show that if you go posterior, you have to extend the fixation, because if you do a short segment fixation without an anterior support, you have a higher chance of having a mechanical complications. So if you are gonna do a short fixation, you have to support the anterior column in most of the cases. And if you do not support the arterial column, which is when it's compromised, you have to go longer in order to decrease the rate of mechanical complications. And of course, if you do, on the other hand, if you do longer construct, you will have higher rate of non-union and adjacent segment disease. So I'm not saying do a posterior longer construct, because we have all other problems associated with it. So in this study, they make a systematic review comparing patients with a low McCormack low shedding classification with studies and patients with higher McCormack scoring system. And as you can see, the higher the score, the higher rate of mechanical complications, even though the rate was low in both groups. So was not significantly higher, but it was higher. I'm gonna bring up some cases. This is an old case, but I wanna stress out the biomechanical components of treating these patients, and so that you can see, I like to show the failures in the surgeries, because if you want to see great results, it's going to be easier. But I think we learn a lot, especially with complications. This is an interesting way of learning. You know, every time you have a complication, you probably won't forget that. So this is a 22 years old female with a L1 fracture. After a fall, you can see the kyphotic in the thoracolumbar region. And in this case, was treated with a short segment fixation without an anterior support. So as I mentioned before, if you don't restore and you do just a posterior approach in these cases, I'm not saying you're gonna have a failure, but the likelihood of having a mechanical complication is higher. And as you can see, there is a progressive loss of kyphosis in this case that required an anterior support to avoid a further kyphotic progression and a mechanical failure. And this is a 57 years of female.
I'm sorry, Gaston. I'm sorry to interrupt you.
Yeah.
I want to open the discussion to Alex about the last case you showed.
This one?
I know he lapsed classifications and scores and the Krebs cycle. I know that things. But in between cases, we have cases with that kyphosis that are pretty well tolerated. Even with conservative treatment, we have 20 degrees of kyphosis with a well-tolerated fractures. And on the other hand, we have 26 kyphosis with a very painful fractures. So we're willing here with two scenarios: to do surgery or do conservative. You show that the evidence is no more farther from one to another. We can do TLSO here and or surgery, and probably the result at the end will be mostly the same. Maybe radiologically will be better with surgery, but we expose the patient to complications. So I think it's a bag of different cats inside and burst fractures. It's like low back pain. There's a lot of things that cause low back pain. There's a lot of different fractures considered burst fractures, as you mentioned. So why in this case you consider surgery against or versus conservative treatment? Maybe the age is an important factor, the kyphosis is an important factor. And will Alex treat this case differently? Why to do a lateral surgery or anterior surgery to restore kyphosis if this patient probably do well with some kind of kyphosis? Alex, what are your thoughts about this?
Yes. Hello, Gaston. Gaston, I enjoyed your talk very much until now. It's hello from Switzerland. Thank you, Alfredo, for handing over this nice case to me. Well, I think the first post-op images you have shown us, Gaston, pretty nicely demonstrates what I have done several years ago exactly the same way. So this is the USS fracture system, I guess. It was the same system I used. And you see the fracture clamps in the L2, and you see the special clamps in T12 when the screw heads are more narrow. This is a nice but historic image. So I think everybody today would do it a little bit differently, would say I go 2 up, 2 down, make a more stable, longer construct from the posterior just to prevent anterior support. But that time we only did bisegmental instrumentations. This USS system was meant to be used in a bisegmental way. If you want to do it like 3 or 4 segments, you have to deal with a lot of technical problems. These fracture clamps are huge. In the thoracic, in the TL junction, you fall into big troubles, and you have to be a skilled surgeon to place the shunt screws properly and anticipate how the rods will be mounted, because you don't want to bend these rods. So coming back to your question, Alfredo, for sure, I would treat this operative because I classify this as a hyperflexion injury with a burst component. But the major injury is not the burst component, it's the PLC injury. I think I haven't seen this CAT scan, but the widening of the spinous processes and the amount of kyphosis is very suspicious for me that this is a B-type injury. And in the young patients, I want to prevent post-traumatic deformity, and I fix them up front. I don't try a conservative treatment. This is the way I was taught by not by Margel, but by Margel's pupil, Jeannery in Basel. And they invented this AO fixateur, this USS system, and they have had a lot of good experience. I would have treated these the same way as Gaston did with the bisegmental, and then I would have watched whether the patient needs anterior support. I a little bit disagree that this was a failure to not do anterior approach up front, because some patients do pretty well and don't run into kyphosis. And I'm bad in looking into the future. So I would have done the same, fixing it from the back. Today, a different way, 2 up, 2 down, but that time I would have used the USS fracture system exactly the same way, and then observed whether the patient runs into kyphosis secondary again or not. So thank you very much, Gaston, for showing these beautiful images, because this is where we came from. This is traumatology of the spine, the beginnings. And if we now see, as you mentioned, the beautiful working constructs, one shot, everything was fine, we don't learn the biomechanical principles.
Thank you very much for your
Awesome.
comments and the way you describe this treatment option. That was really informative and great for the audience. So Alfredo is okay, I can move on?
Yeah, sure.
Sure. So this is another case with an L2 fracture, which at the beginning looks like okay, no neurological compromise after MBA. You can see the component of the comminution of the vertebral body. Apparently, there is no PLC injury in this case. So the patient was treated again, one level above, one level below. You can see the vertebral body doesn't look that bad. And again, after follow-up, you start having some kyphotic, and not that much, was not a big problem, but you can see probably not so bad complication, but you can see that the break and the screw. Patient did well without any further surgery, but again, we are stressing the biomechanics of this treatment option. So if you have these type of fractures, and probably you will either decide or do a combined approach or extend it to level above and below to have a better distribution of the forces along this region of the spine. But this was not so was a complication that we didn't require any revision surgery in this case. And this is
I got a question about
yeah.
that case. Sorry to interrupt you.
Yeah, sure.
You think this would be different if you do percutaneous screws and remove those screws at a certain set point, like 9 months or whatever? Because we see in the literature that it's the outcomes of fusing versus just instrumenting these fractures is mostly similar. So if you don't fuse that disc space, like in this case, 1, 2, and 2, 3, the spine is fighting against the screws until someone's going to lose, or the spine is going to fracture, or the screw is going to fracture, or something's going to fail. But if you give time for the fracture to heal and then you remove the screws, it might be a hybrid set of treatment. What do you think about that?
Yeah, that's a great comment you made, because I think I would consider a PERC fixation in this case, and also probably there are a lot of studies supporting the use of screws in the index fracture, so in the level compromise, to increase the biomechanical strength of the construct. And as you already mentioned, if you don't have that much kyphotic in this case, and I think it's a good option to go PERC. And then once you have some consolidation in the fracture in the vertebral body, that is gonna support and it's not gonna progress to progressive kyphosis, I think it's a great approach. And you will see some cases following this one that show the same, this type of approach. I think PERC is a good option.
Awesome.
Yeah.
Awesome. Thanks.
And
Gaston,
yeah,
would you today consider even more less invasive treatment options like kyphoplasty for these burst fractures without a big injury problem in the back of the PLC?
yeah, exactly. I also consider augmentation in these cases. And not in a young patient, but after over 50 years old, 57, 60 years, I will consider augmenting these fractures. Yeah, definitely. And even in some cases, that's the one I will show you after this one, the augmentation of the screws as well, to increase the mechanical strength of the support. Yeah. And in this case, So this is a 57-year-old male. This is a frailty patient with a liver alcoholic disease and osteoporosis. You can see this burst component L3, and this is the MRI with the no neurological compromise, but the compromise in the vertebral body. This is the CT scan. So this is an A4 fracture that we recently treated. And this is the image in the first stage of the surgery. We did one level above, one level below. We cemented augmented the screws and put also an index screw on the fracture on one side, and then we support this with the expandable cage on the level. I would like to hear any thought on this, any thought on this treatment, because as I mentioned before, I went short in this case, but I support the anterior column, right? So I would like to hear any thought of this.
Yeah, Gaston, I take this case. I think we
Okay.
can nicely see here that it makes sense to not make compromises, too many compromises. So without cement, I think the construct would fail. Without anterior support, the construct would fail. So I like this very much, that you do it 360. I was a little bit afraid that you only did the posterior instrumentation with index screws. Of these, I've seen so many going down. The superior screws are cutting through the end plate. The patient goes into a wedge and is in maybe a miserable situation. So 0 or 360. You can treat these conservatively if they have no neurological deficits. Some of these frail patients, some of these not so compliant patients do pretty well. We have some who refuse any treatment, so it's not our decision. We do some recommendations, but the patients refuse to follow our recommendations. And hello, these patients are coming back 3 months later in a pretty good shape, without severe kyphosis, with a sclerotic healed fracture. And I learned a lot of these patients who were not listening to my advice and still doing fine. So conservative is possible. 360 is possible. Something in between, I think something in between, only posterior, short with index screws will fail. So I like this approach you've performed.
Thank you. So yeah, next time I will probably call you before approaching this patient. So you can see the immediate post-op CT scan was okay, a slight subsidence on the on the above, and the week after, this patient now have a neurological compromise, start having a severe back pain, radiating, shooting pain down both legs. So now we have a mechanical complication in this patient with a severe subsidence, leakage, and dislodgement and kyphosis again. So I bring this bring this case because sometimes we believe that biomechanics is okay. We read the paper, we see, okay, we have seen this, we have the background literature, but we have to remember that osteoporosis is a complete different beast. It's a big problem, and I don't think the biomechanical studies usually consider the osteoporotic in all the specimens. we have to remember that the biomechanical studies usually are done with a few specimens, because it's, you know, expensive to have many samples to test. And also the specimens that usually are tested, they can have different bone mineral density. So what I want to show you is that osteoporosis would change everything, and we probably or either do not operate on these patients, reconsider the decision, as you already mentioned before, if you don't have neurological compromise, we try in a frail patient, try to manage the pain and try to not to surgery, or consider other options. So in this case, we went back to the lateral approach, reaccommodate the expandable cage in a way that do not compromise the canal and the compressed from anterior. And then we extend the construct one level above and below, with laminar hooks as well, that theoretically provides better support in the cortical than in a cortical bone. And patient did well, hopefully. But yeah, so this case was, we wanted to stress that sometimes we try to do something, and osteoporosis can change everything in this case.
Gaston,
yeah,
may I just, from a technical note, if you please can go 3 slides back, where the last intraoperative image of the cage was seen. Yes, I usually want to fill the cement from end plate to end plate when I do these surgeries. And I learned from a colleague, Tobias Hüfner in Hanover, who did this corpectomy, and then he placed a Yamshidi needle into the upper and lower, directly under the over or under the cage end plate, and filled these voids with the cement. And I had a pretty amazing, good series of surviving expandable cages, even in the bad bone, like multiple myeloma. This is the major concerns for me. Weak bone, but sometimes necessity of doing 360. And then I really augment with a Yamshidi needle in the lateral approach, and it works pretty fine.
That's a really good key point, and I think for the next time we are gonna consider cementing much more than these cases. That's a good observation. Thank you for that. So, the patient did well. Hopefully he can maintain like that. So how can we minimize the risk of combined approach? So these cases are from Sebastian Bigdon, a colleague, a German colleague that is working in Switzerland. And I think it's an interesting hybrid way to consider the treatment of these burst fractures, in which you're gonna indicate the surgery. So we have here a 30-year-old female, fall from a horse with an A3 fracture. And they perform PERC fixation one level above and below. And as you have the hemivertebra spare in the lower level, just compromising the upper level, they perform this one level hemicorpectomy. And this is the result. And after a few months, they remove the PERC screw. So you are just fixing one level instead of doing a complete corpectomy, which is, as you know, associated with higher operative time, probably slightly higher complication rate or blood loss. So this is, I think, is an interesting approach, because you are still doing a combined surgery but this is probably less invasive than the traditional situation. This is a similar case, but with an A4 fracture. You can see the lower end plate fracture component. So they did a similar thing with a compression screw in the lower part of the vertebral body, but with the same thing. They removed the PERC fixation, and by doing that, you can just sacrifice, if we can say sacrifice, just one level. So I don't know if you have experience in this type of treatment, and what do you think about it? But I think it's an interesting way to do it, to treat it.
Yeah, we all tried these cases, and this is why we have these tiny expandable cages in our set, in our system. Even we can do it with a monosegmental fusion, when we put really descending screws, starting in the pedicle more cranially and then descending, that we can do the PERC fixation and the anterior support without necessity of a removal from the posterior. So this is, but I can just mention, you need good bone. You need a good bone stock in a patient, in a female patient like 50 years old. You can run into big troubles. But it's smart. It's smart to only fuse the injured level and not to sacrifice another motion segment. It's a good approach, and it's very important that we try these kind of treatment. Sometimes the outcome of the other group, where a motion level is gone, is so good that we don't find clinical differences. So a lot of effort, a lot of challenges, and the control group is doing really fine. This is trauma. Trauma is always nice because the outcome is a lot better than in deformity or degen.
Yeah, that's true. Hopefully we can have some literature in the next few years discussing these new strategies, or to see how it goes compared to the traditional ones. So my take-home messages are: consider the concept of stable and unstable fractures. As you know, stable fractures can be treated conservatively, and stable probably should be treated surgically. Consider the surgery also in multi-trauma patients, neurological compromise, progressive deformity. We can have complications with posterior-only approach. They are low usually, but do happen. The comparison between combined and posterior-only approach are biased, remember, because we have worse cases receiving combined approach, so the comparison should be carefully considered. And the rate of complications maybe can be lowered down through these MIS approaches, such as the hemicorpectomy, but this is just a briefly comment without literature evidence compared to the other statements. Thank you very much for this opportunity.
Well, thank you, Gaston. It was an amazing overview of for this common topic that still have a lot of concerns and things to discuss. We will have you soon again at a virtual global spine for sure. Thanks, Alex, for joining us. Thanks, Ali. I will see you next Thursday for the next weekly session of virtual global spine. Thanks, guys. Good evening.
Thank you, Gaston. It was wonderful.
Thank you very much for your comments.